Next, we're going to be talking about disorders of the lower GI tract. So these are things really starting below the level of the duodenum and the stomach into the small intestine, large intestine, and the rest of the abdomen. First one we're going to talk about is peritonitis, which is like an inflammation of the abdomen almost. So the peritoneal space, it's all that connective tissue and everything around the small intestine. So this isn't a disorder necessarily of the digestive tract. It's the area right around the digestive tract, which is what we're really looking for. This can either be localized or a generalized type of inflammation. So it's an itis problem, meaning an inflammation problem. Reasons patients can develop peritonitis. Ruptured appendix is a big one. That would be a localized peritonitis, especially while they just have an inflamed appendix or a very recently ruptured one. Perforated ulcer, so those gastric or duodenal ulcers, if they perforate fully into the abdominal cavity, that's going to irritate and damage some of that connective tissue around the intestines, so causing a peritonitis, or trauma. So we're talking about blunt abdominal trauma, which is going to cause inflammation to some of those connective tissues around the bowels. So for our assessment stuff, one of the big things we're looking for as a nurse assessing this type of patient, a rigid abdomen with guarding. So guarding meaning patients are going to try and defend themselves. And a rigid abdomen, it's not like, ooh, they got like rock hard abs or something like that. You palpate on their abdomen and it's like this wall, right? So it is rock hard. It's not normal like, oh, you're flexing your abs and you're so cut. It's not that kind of rigid. It's something very, very different. And when you palpate it, you're gonna know that it's like, this feels very different than something that should be going on. These patients are gonna be restless. They know something's wrong with their body. So they're going to have kind of this agitation or kind of discomfort presentation, fever and chills. So part of what goes along with any itis problem, any inflammatory problem, is we have a rush of white blood cells to that area of inflammation. It's part of our regular inflammatory response. So part of the body's natural response here will be to produce fever. Because it's such a large area of inflammation, it can elevate the body temperature. Rebound tenderness, it's one of those specific ones for appendicitis. So what we do, right lower quadrant, usually when you push down in that area, patients won't have pain. But the rebound tenderness is when you let go. If they have an inflamed appendix, that's when that pain is really gonna exacerbate and send them just through the roof. It's gonna be immediate 10 out of 10 pain as soon as you let go of their abdomen, which is the rebound part of that. Also dumping syndrome, that kind of rapid movement through the GI tract, it's gonna cause some peritonitis and inflammation around the lumen of the bowel because of that rapid motility through there. So our GI assessment is our big focused exam that we're looking for patients with peritonitis. Oops. For the medical diagnosis component of peritonitis, we're looking at non-invasive things first, right? We always want to start least invasive to most invasive with interventions. So do physicians. So first we need to identify the problem. Things that are going to happen, they're going to check a CBC on these patients looking for leukocytosis, which is a very fancy way of saying elevated white blood cell count. So these are going to have patients who are going to have a white blood cell count greater than like 10 or 11. It's usually going to be in the teens kind of region. An abdominal x-ray looking specifically for free air or fluid around the abdomen, right? Not necessarily in the lumen of the bowels, but in that interstitial space, in that kind of peritoneal space around the lumen of the bowel. And then a CT or an ultrasound to visualize that inflammation. So this is a colorized CT scan where you can kind of see the different organs, so the liver, stomach, spleen, that kind of stuff. And all this green is inflammation. This is the peritonitis. So we have a very active and severe peritonitis in this patient. All that inflammatory tissue which is compressing on the abdominal organs. If we can identify a peritonitis through non-invasive means, then we're probably going to be moving towards a more invasive intervention for these patients, at least the physicians are. So things like a peritoneal aspiration, right? So aspiration meaning pull some fluid out. So they're going to stick a needle into this inflamed space and see if they can pull out any fluid that'll help them identify what's causing this peritonitis. Because getting to the etiology is the key factor in determining what kind of treatment is going to be applied to this patient. So we're looking for specifically for blood indicating a perforation, or pus indicating some type of generalized infection that's going on in the abdominal cavity. There may also be a lavage that's applied while they're doing this kind of peritoneal aspiration. A lavage is a fancy way of saying wash it out and clean it. So they'll instill fluid, like a sterile solution, to try and rinse it out to get any of the pus or blood that's present in that cavity out to try and clean it up a bit. So for us as nurses, we've got our different diagnostic priorities around these patients, and a lot of them are risk 4 problems because there's a lot of complications that can come about from peritonitis that we need to be prepared for our patient. So things like risk 4 deficient fluid volume, right? So now we're talking about hypovolemia. That massive inflammatory response can push patients into a hypovolemic state. The other big concern is if they have a ruptured or a fully perforated ulcer and are bleeding into their abdominal cavity, the abdominal cavity can hold a lot of blood before patients start presenting with symptoms. So they could be very hypovolemic by the time they have that rigid abdomen presentation. Risk for electrolyte imbalance. So again, patients with dumping syndrome, we're starting to get into the etiologies of these problems. So if patients have peritonitis secondary to a primary cause, that primary cause is what's going to be giving us a lot of our concerns in the nursing world. So if they have dumping syndrome or electrolyte imbalance, decreased cardiac output is kind of piggybacking off of our fluid volume status, right? So now we're talking about shock is a big thing for this type of patients. So they can have a few different types of shock: hypovolemic shock because of circulatory volume, cardiogenic shock because of decreased cardiac output, and septic shock because of infective processes that are going on in the abdominal cavity. So shock is another big one, or risk for hemodynamic instability is another big nursing diagnosis that we're focused in on for these types of patients. So the medical plan. First and foremost, medicine, their goal, so medicine meaning not people with knives, maintain circulatory stability. Hemodynamic stability is the big thing for these patients. First and foremost, it's our ABC problem for peritonitis. Excuse me. So fluid volume resuscitation, so normal saline boluses to make sure our patient is hemodynamically stable, and electrolyte replacement as needed. We're especially looking out for things like sodium and potassium levels, which are very sensitive to changes in circulatory volume. Antibiotics is another big one that our medical team is going to be focused in on. So it's going to be broad spectrum, really gnarly, high potency antibiotics that are given IV. We can also do a direct abdominal infusion for these patients. So if they've had that puncture site into their abdomen where it did that washout, we can instill antibiotics into the peritoneal space in order to treat infection at the source. This is something that we do commonly with a ruptured appendix, where we have introduction of non-sterile materials into the abdominal cavity because the bowel has ruptured. Then there's surgery. So surgery is, for peritonitis, we're looking at laparotomies. Laparotomy is kind of a fancy way of saying a laparoscopic exploratory surgery, right? So it's that category of surgery. It's like you never really want somebody to be like, well, let's go in and explore your belly. That seems cool. That does not seem cool at all. But they're going to do it laparoscopically, which makes it a little bit better than like just open you up and see what's in there. So here's kind of what that's going to look like. They're going to introduce their laparoscopes to take a look around, look for the area of inflammation, whether it's an appendix, whether it's a massive bowel obstruction, whatever the source may be. They're going to try and identify the cause of that peritonitis in that patient. And then again, they can lavage while they're doing this procedure, meaning clean it out and to get rid of any infective material, especially with our ruptured appendix where we have bowel contents leaking into the peritoneal cavity. Our nursing plan, we're going to be looking for that IV therapy, right? For that volume resuscitation to maintain hemodynamic stability. We do not want our patients becoming hypovolemic and going into shock because of that. We're going to monitor electrolytes and look out for antibiotics to either be instilled through an IV, so they're going to have a circulatory effect, a generalized effect, or direct infusion into the abdominal cavity. Frequent GI assessments are the name of the game. These are going to actually not just be a GI assessment, but a focused assessment. We're going to continue looking for those symptoms that our patient's presenting with of peritonitis. That rebound tenderness, that hard abdomen, that rigid abdomen, and also some of the vital signs changes that will go along with these large-scale inflammatory responses. Infection assessments, so we're looking for vital sign type things, right? So temperature, pulse, blood pressure, respiratory rate, any of those symptoms that our patient might be becoming infected. Subjective and objective signs of fever, those types of things as well. And we want to prepare our patient for surgery. Let them know that that's a thing that may happen, and it'll probably be done laparoscopically, so it's going to be a minimally invasive surgery. Because we do need to identify the cause of the peritonitis before we can effectively treat whatever disorder is going on with our patients. So surgeons are often going to call peritonitis, well, most medical people, not just surgeons, are going to refer to peritonitis as a hot belly. The reason for that is there's a massive inflammatory response on there. Sometimes when you just touch their abdomen, it'll feel hot. But there is a big inflammatory, if not infective process going on in here. So here's kind of a general kind of infographic about all the things that go along with that. We as nurses want to really focus in on the risk factors here for patients with peritonitis, like surgeries and perforation, right? We don't want that bowel to perforate because of a ruptured appendix, some kind of ulceration or trauma, because then we're going to have a lot of problems. The nursing care, again, IV and electrolyte replacement. Watch out for infection, right? We're going to be doing some of those interventions to promote or manage the infection response in our patients, manage their fever, manage the infection that's going on with their white blood cell count. So look at their white blood cells to see if they're showing signs of that inflammatory or infectious response, and look for antibiotics to manage that and prevent complications. So we still need to get these patients moving around. We don't want that inflammation to cause things like constipation or other complications of immobility on top of what's going on here, with what's causing that peritonitis. Sorry, it's a more specific way of saying that. So for implementation, IV therapy, big thing. We want volume resuscitation to prevent hypovolemia. So we're looking for things like a low blood pressure, high heart rate, indicating that we need to give some fluids to these patients. Also things like electrolyte imbalance, all of that supplementation is going to be based off their lab results. So if we see a low potassium, we'll give potassium, right? Antibiotics, so again, lab monitoring for antibiotics. One of the big ones we give for peritonitis is vancomycin. Vancomycin is a nephrotoxic antibiotic. So we're going to be looking at lab monitoring for two things. One is kidney function, to make sure that we're not damaging the kidneys as a result of giving this medication, the vancomycin. Also, we're going to be doing therapeutic drug monitoring. So we're going to be measuring trough levels on that antibiotic as well. Very frequent GI assessments to determine if the patient is acute, meaning they're very sick, or subacute, meaning they've got a problem, but they're hemodynamically stable. Hemodynamic stability is really the differentiator between acute and subacute, and we're talking about a peritonitis presentation. If they do put an NG tube in because we have a gastric or duodenal ulceration that's perforated, we need to suck out some of that contents. These are going to be to suction. We never want to leave an NG tube placed for a peritonitis presentation that isn't to suction, right? We need to remove that stomach acid so we don't continue to allow that area of injury to get larger or to re-injure as a result of introduction to acid stomach contents. Then infection assessments, so signs and symptoms, right? So we're looking for fevers, subjective and objective symptoms of fever, vital signs changes, lab changes, or white blood cell count is a big, big deal when we're looking for infection in these patients. Also, our neuro assessment is a big one, especially as patients advance in age. One of the things that happens very, very quickly is if they get an infection, their neuro status tends to decline pretty quickly. We see this definitely with peritonitis, but we also see it with much less severe infections and inflammations. Things like UTIs, like bladder infections, can cause major changes in a patient's neurologic status. So whenever we're talking about monitoring for infection or assessing for infection, we always want to include the neurologic system. Are they ANO times 3, 4? Are they responding and cognating appropriately for that patient's baseline? And then surgical preparation. One of the big things, if they start becoming hemodynamically unstable, this may happen really fast, right? They may have to go to surgery really quickly for that abdominal washout or to remove the source of their peritonitis. So we want to be very careful in how we set up our care for these patients and always be ready for them to go to surgery within an hour of whatever kind of diagnostic stuff is going on at that time. One of the other big things is because that inflammation is going on all over their abdomen, they can have alterations in GI motility. Gas pain can be a big problem associated with peritonitis. And patients with gas pain, the big thing we want to do is we don't just want to give medications for that type of pain. Because a lot of the medications we're going to be giving are actually going to exacerbate some of our low motility problems, right? So if we're giving narcotics, as an example, that's going to decrease GI motility, causing more gas pain down the road. So our number one intervention for constipation, for gas pain, that kind of crampy abdominal pain, is get up and walk. Walk it out. That's going to increase peristalsis through the GI tract, and it's going to decrease their pain much more effectively than any pharmacologic intervention that we could give them. So for evaluation, first our ABC issues, right? Are they hemodynamically stable? Have they maintained their circulation? Is their infective process resolved? So now we're into the etiology. Has the underlying problem, the reason they developed peritonitis, been resolved? Whether it's from a ruptured appendix, which could be our infective process, or whatever other underlying disease might be going on causing that peritonitis, including dumping syndrome or perforation of their gastric or duodenal ulcer. Usually the primary so peritonitis usually isn't going to be what they're diagnosed with. It's going to be part of how they present. So we always need to make sure that the underlying cause is what's addressed in the treatment. So if you're reading through physician notes on a patient with peritonitis, you're not going to see diagnosis peritonitis. You're going to see things like diagnosis ruptured gastric ulcer, ruptured duodenal ulcer, appendicitis, right? The peritonitis is part of the symptom or syndrome that's going to go along with that. But the underlying disease or the underlying cause is usually what you're going to see in the documentation. So that's peritonitis. Next, we're going to get into kind of the inside. This is like an inflammatory disorder outside the bowels. Next, we're going to look at inflammatory disorders inside or affecting the lumen of the bowel.